AKT webinar on menopause and ADHD. Menopause, of course, being a hot topic. A lot of trainees struggle with menopause as a topic, so it'd be a good way of getting your knowledge base down, and obviously expanding on the existing knowledge that you may have. So Dr. Sandhu is going to do a quick introduction whilst I get this streamed to our Facebook group, and then hopefully we'll get started.
Brilliant. Welcome, guys. Thank you very much for joining us. So Dr. Sandhu from iMedics, obviously Dr. Mo's on the other side. He's just going to stream this live now to our Facebook AKT CSA/RCA revision group. So we'll wait for that to happen. In the meantime, guys, let us know where you're from. This is the exciting bit. You know I get excited about this. So 58 people are now joined, which is great. We've just come off another webinar for a different set of international doctors, which has been great, from all over the world. So now it's good to come back to the local area. So we've got Shilpa from Wales. Fantastic. My brother's from North Wales near Bangor. I was supposed to be there this weekend, but didn't go. Obviously lockdown now as well there. Douglas Pepple from Norfolk. We've got Huma Hussein from Chesterfield. Sarah from London, Shahid from London, Khalid from London. Oh, good, fantastic. So a lot of people from London. Ibida Lupo from Coventry. We are also from Coventry. Whereabouts are you working, Ibida Lupo? Let us know. So we're Coventry lads, and iMedics is a Coventry company. Aisha Tariq from the West Midlands. Whereabouts in the West Midlands, Aisha? Dan from Chelmsford, Essex. Welcome, Dan. Fariha from Harrow. Unjum from Manchester. Edgy Men from Coventry, another Coventry, fantastic. Welcome. Whereabouts? Which surgery are you working in? We probably know the people there. Ismet from London, Musharraf from Northwest, Madiha from Hertfordshire. We've got Musharraf from Blackburn, Aisha from Dudley, fantastic, great variation. Shakil from Durham, Uche from Durham, Narendra from Ipswich, fantastic, down south. Who did I? Oh no, so Ipswich rings a bell for some reason. I don't know why. Aisha Tariq from Dudley, Aluwula from Coventry. Welcome, Aluwula. Again, what surgery? It's always nice to see people from Coventry. Mamoon from Manchester, Noor from Huddersfield. How cold is it getting, guys, at the moment? It's about 10 degrees at the moment in Coventry. I wonder what the temperature is in Huddersfield today. It's normally colder the more north you go. Now, if you compare that, by the way, so we had a webinar. And it was for international doctors, and somebody said in India it's 28 degrees now, and they're 4 hours ahead, and that's at sort of 10 o'clock at night. We had someone from Oman the other week who told us it was 45 degrees. And I said to him, we're nowhere near that. I live near your office, work at Springfield, a very lovely practice. Fantastic, brilliant, fantastic. So not far from us. Maybe pop into the office at some point. We'll have a look at it once all this social distancing stuff settles and stuff. But fantastic. Springfield is Dr. Briggs and forgotten the other GP now. But Dr. Mo's cousin was a registrar at that surgery. Swansea, Wales, Napoleon. Agoho from Northern Ireland. Fantastic. I don't think we've had anyone from Northern Ireland. That's a first. Wonder what scheme and what GP practice. Or maybe, Ag, you should drop us an email at some point. Let us know what GP training is like up in Northern Ireland. What's your VTS scheme like? Narendra from the River Surgery. Ekin from Lincolnshire. I think Dr. Mo's written excellent. You'll know Dr. Hammond as well then. Kenyan Medical Centre. Yes, I was at Kenyan Medical Centre Friday evening, and I'm there tomorrow as well. So Kenyan Medical Centre, they do the extended hours there as well. So me and Dr. Mo do some shifts in that area. Amar from Norwich, welcome Amar. 12 degrees in Chesterfield, Amar. Okay, it's not too bad. You're a little bit warmer than we are, probably about the same as Coventry. Chesterfield is near Derby, so you're not too far from us anyway. I think you're in the Midlandy area. Okay, great stuff. Dr. Mo, how are you getting in there?
Yeah, good. So we're on Facebook Live in our AKT/RCA group, which is good. So if you're joining us from Facebook, welcome. I can see we've got about 65 attendees at the moment. A couple of housekeeping rules. If you have a comment to make, please use the chat box. If you want to ask a question, please use the Q&A icon or button. And of course, we can answer questions at the end of each presentation, each teaching topics, which is menopause and ADHD. Now, one key thing to note, overnight we moved over to Amazon Web Servers. So obviously Amazon is a huge company. They have extensive they have an extensive bank of servers across the globe. And what happened is, because you guys were using our AKT bank so much, we actually maxed out our old servers. So we had our servers based in France and the UK, and they completely got maxed out and the system was slowing down. So we had to uproot all the servers, move them over to Amazon, and there have been some issues. So Douglas, you are right. It's now showing a warning, not a warning sign, but there's a message showing that the account has been suspended. That's not the case. If you delete your cookies and clear your cache on your browser, the website will show up again. And the only reason it's giving you that message is because we've moved servers. So it's not a long-standing issue. It should be basically disappear as soon as you've done that. So Douglas, hope that answered your question. If you want to get back to us, info@i-medics.co.uk. So guys, let's get started. We will be offering discount codes during this webinar. We've got an AKT mock exam, big mock exam, approximately 9 to 10 hours, 3 hours for the actual mock, 6-7 hours of learning. It's next Sunday, if I remember correctly, and we'll be issuing a discount code for that, so please stay tuned. So let's get started. Going to do a screen share here for everybody. The first topic will be menopause. I know I struggled with this as a trainee. I know a lot of other male trainees struggled with it, and I guess it's it's quite a difficult topic to get your head around. So what we're going to do is we're going to go through ADHD, menopause, specifically relevant for the AKT/RCA, which was formerly known as the CSA exam, and we're going to try and cover the latest NICE guidelines so your knowledge is bang up to date. So the breakdown will be menopause, new NICE guidelines. In the first 15 minutes, we'll do some Q's and A's. And then after that, Dr. Sandhu will go through ADHD, again, covering the latest NICE guidelines for about 15 minutes. And then finally, if we've got time left over, we'll do a general AKT RCA Q&A. So why don't we get started with menopause? I know this is a hot topic because whenever there's been a teaching session done on this in our VTS training group, or whenever there's been a teaching session.
Sorry, Dr. Mo, just going to interrupt once. So just got a message from Facebook. So I think somebody's watching on Facebook Live. Just make sure, not from our side, I think everybody can hear because we've not had any problems, but the person on Facebook Live is just questioned. Just check that your little Facebook thing is not on mute. And check the volume on your laptop and stuff, because you should be able to hear us. Yeah, okay, perfect. Over to you, Mo. Yeah. Hello?
Yeah, fine. I'm just reloading up the screen share once more.
All right.
Okay, so it's always been a hot topic. Whenever there's been a presentation on menopause, there's been loads of questions. So it'd be a good topic to go through today. So as before, guys, basically, I'm going to try and highlight 3 key learning points, which are going to be super, super relevant for the AKT, but also for the RCA. And so this is like the knowledge base that is most likely to be tested for the purposes of the exam. Now, I'm not going to try and cover all of menopause within a half an hour slot. It's not doable. The topic's far too big, but at least you walk away with some information that's going to be relevant. And if you walk away with 3 pieces of knowledge from menopause and 3 pieces of knowledge from ADHD, you're doing well within an hour. That's fantastic. So let's do a recap. So you should already know this information. So the definition of menopause is obviously the absence or the cessation of menstruation, which occurs at the end of a woman's natural sexual her natural reproductive cycle. And it normally happens 12 months after the end of her last period. And the mean age in the UK is usually 51 years of age. Now that can vary depending on the ethnicity, but in the UK, the average age is 51. So that's some key definitions to keep in the back of your head. 12 months from the end of the last period. And obviously it's the cessation of menstruation, and the average age is 51. The other things to know about, and again, this is a recap, are classical symptoms. So we all know, and most of us should know that with the menopause, you start to get hot flushes and night sweats, for example. You can get an effect on your mood as well. So women start to experience, for example, irritability, or they may develop mild features of depression, for example. And then there's other symptoms, MSK symptoms, vaginal symptoms, urinary symptoms. So with regards to MSK symptoms, women can start to experience pains and aches generally. They can start to experience vaginal dryness down below, which of course can affect their libido, because if it's dry down below, they may not want to have sex. They can start to experience urinary symptoms, so frequency of urine dysuria. Again, that's associated to the dryness down below. That increases the risk of a UTI. And then I've mentioned loss of libido, which is one of the symptoms of the menopause, as well as sleep disturbance, which can be related to night sweats, and it can make sleeping very, very uncomfortable. So again, this is a recap. You should already know this. It should not be new knowledge. This should be stuff from medical school, stuff that you've done on your VTS and perhaps even during your junior doctor years. Now let's move on to what's going to be tested for the purposes of the exam. So 3 key learning points, and let's start off with the first one. So HRT is a big topic within menopause. Some doctors feel very, very uncomfortable sometimes starting HRT because they don't know which one to start, how to properly assess a patient start HRT. So really, I'm going to focus on HRT within this webinar, because it'll give you a very good foundation in terms of preparing for the exams, but also with interacting with the patients who come in requesting HRT. So there are, firstly, some known contraindications to prescribing HRT, and I've broken them down for simplicity into 3 key areas. One is cancer, second is cardiovascular, and if you think of cardiovascular, it's also composed of the venous and the arterial system, so putting clots at the same time, and then finally the liver. So if you can break it down in your head, if you're seeing a patient, okay, contraindications, cancer, cardiovascular, liver, you mostly are going to cover all the key areas. So what do I mean by these 3 key areas? So contraindications in terms of cancer is if the patient has an active history of breast cancer or a past history of breast cancer. Of course, prescribing estrogen or progesterone in patients who've had previous breast cancer can obviously make problems worse or cause certain cancers to reappear if there's a small amount left in the body somewhere. So you might have, for example, a estrogen-dependent breast cancer. Also, some cancers are estrogen sensitive, like I mentioned with the breast cancer, but other cancers are sometimes estrogen sensitive within the gynecological system. Undiagnosed vaginal bleeding, that's also important. The reason that's important is it could represent something like endometrial cancer, and therefore you need to diagnose and work out what's going on there. Obviously, you need to investigate further. So that's a contraindication. And then finally, if you have untreated endometrial hyperplasia, which can again point towards endometrial cancer, that's a contraindication for prescribing HRT. So the first category would be, if a patient comes to you, does this patient have any contraindications which fall within the category of cancer? And you're thinking breast cancer, estrogen sensitive cancers, you're thinking endometrial cancers. And again, those are the questions you want to be asking within the first 4 bullet points. Moving on from there, you've got your cardiovascular contraindications, and this is stuff like PEs and DVTs. And that's the first bullet point. You've also got your arterial embolus type scenarios, which are basically like angina and MIs. And then you've got untreated hypertension. So if you have a patient who has untreated high blood pressure, let's say 160/95, that will be a relative contraindication for HRT. And then finally, thrombophilic conditions which increase the chances of a blood clot developing. Again, that will be a contraindication. And the reason is obvious. You're prescribing HRT, they can slightly increase your risk of venous thromboembolisms or embolisms in general, and therefore you want to avoid that by screening for any relevant history. And then finally, the other contraindication is liver disease, acute liver disease, but specifically associated with the abnormal LFTs. The NICE seem to make that very clear. It's not like acute liver disease by itself, which is in remission. It has to be acute liver disease with abnormal LFTs associated with it. Why, I'm not quite sure, but that's one of their criteria. So first of all, if you see a patient in the RCA exam when you're recording and you're going to prescribe HRT, make sure you've screened for the relevant contraindications, because if you prescribe it and you've missed something or you haven't asked, then obviously you could fail that station. And then finally, for the AKT exam, you may get a question on which one of the following is a relative contraindication for prescribing HRT. And you might have a 52-year-old lady with hot flushes. If you can pinpoint one of those points, one of those contraindications out, you've got yourself a mark. So the first key, this is like the first key learning point from this webinar on HRT. Let's now bounce onto a topic which I think most people really don't like, and that's which HRT do you actually choose? And this is really interesting. It's quite fascinating. So HRT comes in different forms. You've got tablets, gels, and patches. You can use any one of the three. It's important to know that the patches, they're absorbed transdermally. And for that reason, they undergo first-pass metabolism, i.e., the way they're broken down is different to the way oral HRT will be broken down, and therefore mostly patch HRT. The method of delivering HRT by patches tends to be safer overall than compared to tablets, because of the physiology of the breakdown of the actual chemical itself. So that's the first thing to bear in mind. In terms of gels tend to be used around the vaginal area for dryness. That's the most obvious application. You can use it on other parts of your body, but that will be the most relevant place to be prescribing gels. But then coming on to more specific questions, in terms of prescribing HRT, you want to establish whether a woman is perimenopausal or menopausal. So the distinction is that if a woman has had a period within the last 12 months, but they're starting to become irregular, but she's having some symptoms of the menopause, like hot flushes, then she's perimenopausal. But a woman becomes menopausal when she's not had a period for 12 months. So you can quite quickly stratify the patient into menopausal or perimenopausal. So less than 12 months since their last period is perimenopausal. If there's been more than 12 months, then it's menopausal. Now, if you have a woman who is obviously menopausal, so more than 12 months since their last period, and you are looking to prescribe HRT, the first thing will be to establish whether or not she has a uterus. So if she does not have a uterus, you should be prescribing estrogen only. But if she does have a uterus, then you want to be prescribing the combined HRT formulations. And the reason you don't prescribe estrogen alone in a woman with a uterus is because if you prescribe estrogen alone in a woman with a uterus, you'll increase her risk of endometrial cancer. So that's very, very important to know. So no uterus, estrogen alone. With a uterus, use combined. Quite simple formula to learn. So so that's relatively straightforward in terms of prescribing. Where it becomes a little bit messy and I think a little bit kind of difficult in most trainees' minds and probably a lot of GPs is when women start to go through are perimenopausal, because then at that point really you should be using sequential combined HRT. Now what does that mean? What it means is the woman still has a certain amount of female hormones running through her body, and she's still having period at a certain point in her cycle, like every 2 months, let's say, or every 4 months, because she hasn't quite approached the menopause. And therefore you want to add in reduced amounts of HRT to make sure that she's not going to have the symptoms of the menopause within the perimenopause, and therefore you have to use a different formulation. So the pharmaceutical companies have come up with sequential combined. What that means is there's different concentrations of hormones depending on which one you choose. So there's not always going to be progesterone within the formulation for the entire month, for example. There might be only progesterone in the prescription on the last 14 days. You can see how it becomes sequential because things are changing over. So the way to explain it is for perimenopausal women, you would use a sequential combined HRT. And there's two different types. There's monthly and there's 3 monthly. And the difference is basically both of them have estrogen in them every day, but you would prescribe a 3 monthly sequential combined HRT for a woman who's having a period only once every 3 months, for example. Whereas if a woman is still having a period, let's say every 1 to 2 months, you'd give her the monthly HRT, because what would happen is then she takes the estrogen every day, but for the last 14 days of her cycle, she takes the progesterone along with the estrogen. And then that gives her a normal period, but also it prevents the menopausal symptoms at the same time. Whereas a woman who's perimenopausal and only having periods every 3-4 months, you'd give her 3 monthly sequential combined. And you can check on the BNF which ones are 3 monthly and which one are monthly, because the 3 monthly ones will have like a 84 tablet supply. From the top of my head, 56, 28 times, so yeah, 84 tablet supply. But with the 3 monthly sequential combined, it's estrogen every day, but again, it's you take progesterone for only 14 days within the 3 months, and that gives you one period every 3 months as a result. So I hope that brings some clarity to how you prescribe HRT in menopausal and perimenopausal women. Essentially, one sequential combined, and the other one is this combined. Obviously, it could be estrogen alone if there's no uterus in menopausal women. So that's an overview. The third thing to know is that at some point, obviously, you want to switch a woman over from a perimenopausal woman over from a sequential combined to a menopausal combined, so the normal kind of the non-sequential HRT. And that usually occurs 12 months after you've started the sequential combined, or if the woman's over 54 years of age. So if you've started a sequential combined in a perimenopausal woman, do it for 12 months, then move them over to a regular normal HRT, combined HRT tablet or patch, if that's their preference. So again, I will cover this again I'll cover this again in the summary as I come back to it. But in essence, when you choose your HRT, you make your decision-making process depending on the following factors. And then finally, when you're speaking to these patients, you're counseling them on their HRT risk. You want to obviously counsel them appropriately. This could be a very, very easily an AKT exam question. What are the risks of HRT in a woman who's perimenopausal or menopausal? So there is a known small increased risk of breast cancer. There is a known increased risk of venous thromboembolisms. The risk is less in the transdermal route versus the oral route, because the transdermal route bypasses first pass metabolism. There is some cardiovascular disease risk as well, but you have to be careful here. With estrogen alone HRT, there is no cardiovascular disease risk, or you can actually reduce your risk. With the combined HRT, there's risk when the woman's over the age of 60. The risk is very small, but if she's under the age of 60, there's no increased risk there's no increase in the risk of cardiovascular disease. If the woman's starting HRT, it does not increase her risk if she's over 60. Sorry, if she's under 60. If she's over 60, then there's a slight increase in risk of developing cardiovascular disease, heart attacks and strokes, for example. But again, that applies if she's over the age of 60. And if estrogen alone, there's no risk, or it reduces the risk. Generally speaking, as a general rule, the stroke risk increases slightly, and that would make sense, because obviously it increases the thromboembolic risk, or the risk of embolisms developing, because the patient's on HRT. And the studies, although the studies are not unequivocal, there seems to be a very, very small increase in the risk of ovarian cancer when you start HRT, or if you're on HRT. So that's another thing to bear in mind. That might change in 5 years' time. The studies might become stronger, in which case they say, no, there's no risk. But at this moment in time, NICE thinks that there may be a very slight increase in risk. So I know this was a whistle-stop tour of HRT, and really I wanted to deliver 3 key learning points. So let's just recap those 3 key learning points. First of all, there are certain contraindications to HRT. Think cancer, think cardiovascular/clot related problems, and then also think about the liver, and I've covered those bullet points as mentioned. Then in terms of HRT, which one can you choose? Break it down in your head. Is the woman perimenopausal, i.e. she's had a period in the last 12 months and is having menopausal symptoms, or is she actually menopausal, whereby her last period was over 12 months ago? That will tell you which HRT to choose. Will it be the normal HRT formulations, i.e. combined or estrogen only, or will it be sequential? Sequential is basically when you get an addition of progesterone at some point in the cycle, and it can be either 14 days within a month or 14 days within 3 months, depending on how often the woman has her periods. So a perimenopausal woman may only have her periods every 3 months, so you're going to give her 3 monthly HRT where she gets a 14-day dose of progestogens in a 3-month cycle. But for the rest of those days, she's also taking estrogen. Also remember, no uterus means estrogen only. If she does have a uterus in a menopausal woman, you need to give her the combined. Make sure you don't give those women estrogen only. And then finally, if you're switching over from perimenopausal to menopausal, it's at the 12-month mark, or if the woman's over the age of 54. Finally, just to recap, in terms of HRT risks, increased risk of breast cancer, VTE, and cardiovascular disease in some women over the age of 60, and also an increased risk of stroke. And also there's a very small increased risk of ovarian cancer, but it's very slight, and the evidence at this moment in time isn't too strong. So I'm just going to stop the screen share there because I know that went pretty fast, and we'll take some questions and answers because I'm sure there's going to be a lot. Stella says, what is the current guidelines on giving topical estrogen to a menopausal woman with a past history of breast cancer? It's probably going to be a contraindication, Stella, and the reason for that is because that woman may have an estrogen dependent cancer, and suddenly you start pumping her back, you start giving her estrogen, and if she's got any remnants of cells within her body which suddenly become receptive to that estrogen, you're going to get a recurrence. So that's a contraindication. You shouldn't be giving it. You can use
just to add, the BNF also says that as well, so it lists it as a contraindication. So if you ever found yourself, and sometimes you do find yourself in a situation where nothing works and a patient prefers a topical estrogen, that will be a case that you'd get the advice and guidance. I'd almost certainly speak to a gynecologist or the patient's oncologist and say, look, this is a situation, she wants the topical estrogen, it is a contraindication. Is there a scenario where you've seen it given? But you wouldn't give it off your own back. So yeah, back to you, Dr. Mo.
Yeah, absolutely. So if there's a contraindication, you can actually refer on to the gynae specialist to get further guidance. The other thing you can do is you can give them a vaginal lubricant. I think there are a couple that you can prescribe and available over the counter if there's dryness, obviously, around that area. Shilpa, is a patch preferable due to relatively lower risk of VTE? Shilpa, is patient preference. If the patient wants a tablet because they prefer that method, this explains it's got a slightly higher risk compared to a patch. But you should obviously advocate the lower risk benefit of having a patch, but the end decision comes down to the patient. Overall, they're both very low risk, but the patch is lower risk between the two. Anonymous has said, I've seen a few women tired of heavy irregular menses during perimenopause, wanting to specifically regulate their menses during perimenopause. I know IUS will be better, but please, what tablets will be advisable? Usually you want to offer the POP there. That's more advisable. In terms of, so there's different progesterone contraceptive methods available. If you're talking contraception here, you may want to offer a depot. The depot is very good actually as a adjunct to providing contraception on top of HRT. And the other thing to bear in mind in perimenopausal women, especially if they're having heavy irregular menses, is the sequential HRT is usually quite good in a lot of these women. Most of these women, they'll often get lighter periods. But essentially, to answer your question, don't use the combined with sequential, use the POP. That's the straightforward answer. Okay, Anna, what do you do if the lady has a coil in situ? Good question. So you would often just add on an estrogen type HRT if she already has a coil in situ, or that will be what NICE guidelines usually say. But Hannah, I would double check that on NICE if she's already got like the Mirena coil in place, which is obviously going to be a progesterone type of contraceptive. Then she only needs the estrogen component, because remember, in a woman who's got a womb, you should not be giving estrogen alone. Let's double check that. Yeah, you shouldn't be giving estrogen alone in a woman with a womb. So if she's already got a coil in situ, you should probably offer an estrogen on top, perhaps as a tablet, for example. Anna, what do you do if the lady is in premature ovarian failure, sequential combined? I'm not quite too sure about that situation. because it's almost like the woman's going through the menopause effectively. I guess it depends on her symptoms. If she's going through premature ovarian failure, I guess physiologically it makes sense to offer sequential combined because she hasn't quite finished her periods. So I guess that probably would be the answer, unless it's been 12 months since she's been on the sequential combined, in which case you switch her over, or unless she's over the age of 54. Again, the NICE guidelines seem to suggest over the age of 54, they shouldn't be on sequential combined, they should be on the regular HRT. Anna asks, young ladies post-hysterectomy, estrogen only would be fine in that case. If they're experiencing menopausal type symptoms. Under the age of 51, do hormone tests need to be done to confirm menopause? You can offer them. That's not unreasonable. I think NICE is quite clear. If a woman's around the age of the menopause and she's having menopausal symptoms and she hasn't had a period for like 12 months, you would diagnose the menopause. If it's unclear what's going on, yes, you could request some blood tests, but certainly I think if the woman's 45, 40 and there's no family history, it'd be reasonable to do FSH, LH levels. Lena, if a 69-year-old woman asks for oral HRT specifically, is it all right to prescribe, or is there an age limit? No, you can prescribe it, I suppose, if she is having menopausal symptoms. Obviously explain the risk and the benefit at the same time. Madiha has got sequential HRT 3 monthly. Progesterone is given once in 3 months, or is it given every? Okay, so sequential HRT 3 monthly, Madiha, you would give 14 days of progesterone, or progestogen, whichever one is the progesterone chemical, within the 3-month cycle. So effectively, they'll get estrogen every day, regardless, but within the 3 months, they get 14 days of progesterone. Shahid, choice of contraception for a lady with a history of breast cancer and recent menopause. Good question. I wonder if you'd go for the copper coil in that case. Copper coil probably be one option. Mirena may be another option. I think the copper coil will probably be the obvious choice there, as well as condoms, for example. NICE isn't too clear on the overlap between the menopause and contraception, because they break it down to 2 topics. So you have to do a bit of reading, but I would assume the copper coil would be an obvious one. Where should the patch be located? The patch can be located anywhere, as long as there's not much hair there, which would impair absorption, to anywhere on the body where there's not much hair. Huma, is Conti combined HRT given in menopause? A continuous combined HRT. Huma, can you clarify your question? If you mean the combined HRT in terms of a if you mean continuous combined HRT in terms of the non-sequential combined, then that should be fine. But if I haven't answered your question, just clarify it. Guys, we're just going to take a few more questions because there's quite a lot of these questions, and obviously we've got another topic. What's the advice on stopping HRT post-total hysterectomy with bilateral cell removal of ovaries as well? It's a difficult one. I think most GPs would probably try and stop it within about 5 years, because the studies seem to suggest that if you prescribe HRT for more than 5 years, risk of various complications like, for example, VTE, cancer risks tend to go up after the 5-year mark significantly compared to the first 5 years. So I'd use that as a benchmark, probably about 3 to 5 years in terms of when you would want to stop it. Musharraf says, how we cover this much knowledge in the consultation? It depends, Musharraf, on the consultation. So obviously data gathering, you ask certain questions to do with contraindications, and then management, you would cover certain things. So that's something, it's a skill set you need to develop. Come on to our RCA coaching. We do one-to-one coaching where we talk you through how you can deliver this much knowledge in a consultation whilst being patient-centered. Huma says, I know you mentioned perimenopause sequential combined. I'm not sure if that's a question, Huma, but let's clarify that. What is the best medication to increase libido in menopausal women? Testosterone. It is off license and it can only be prescribed by a specialist. There's a nice EKS topic on it. Please have a read. Narendra, what is the age limit for HRT? There isn't no age limit per se, Narendra, so that shouldn't be a contraindication. Huma, sorry, I know you asked a question, but I've lost the thread of it. So if you don't mind posting it again or emailing us at info@i-medics.co.uk. So guys, I'm just gonna hand over to Dr. Sandhu for a second, and what we'll do whilst he's loading his presentation is he'll show you. Sorry, I think Dr. Sandhu is going to show you the AKT mock exam. and we can do a discount code on that today. So who's hands up, who's interested in the AKT mock exam, either in the next 12 months that we do. So it's a 9-10 hour mock. Basically, we do 3 hours of 200 questions for the AKT, and then we do 9 hours or 7 to 9 hours of intensive learning. So guys, hands up now, I've just lowered them. Who's interested in the AKT mock? And Dr. Sandu will do a screen share to show you where you can book in. So there's 6 hands. Okay, guys, what we'll do is we'll offer 10 hands. 10 hands went up. For the first 7 doctors who book in for the AKT mock, any date, you can choose any date, you'll get £50 off. And the discount code is 502020. So Dr. Sandu, if you don't mind putting in the URL for the AKT mock, you get £50 off the AKT mock. There's one coming up next week on Sunday, and then there's one, I think, a few months down the line, and one next year. There's about 3 different dates that we have, and the first 7 who book on, they'll get £50 off, and then the system will lock out. What will happen is you can't apply that discount code after the first 7. So if you're interested in that discount code, it's a full day, it's on a Sunday, it's a Zoom mock, you can do it from home, nice and relaxed, 1 hour break between the question and the feedback. Me and Dr. Sandu are present. We're going through all the different relevant NICE guidelines. We're going through stats. We're also going through health administration. The first 7 who book will get £50 off. There's the link within the chat feature itself. Please, please, please book in as soon as possible. Once the first 7 have obviously booked on, you'll lose the opportunity to get £50 off. And then Dr. Sandu, do you want to do a screen share and quickly show
just put the, I think you've disabled my thing again.
Okay, and Dr. Sandu will also show you our high yield RCA videos, which we've done in-house, which break down the consultation for the RCA exam minute by minute with examiner feedback inside it. And again, for that, we've got a 30% discount code. So Dr. Sandu is going to do a screen share shortly. They're RCA gold standard consultation videos. The first 5 trainees who manage to buy the product can get a 30% discount code, and the discount code is 302020. Only the first 5 who apply for that discount code will be able to use it. The AKT course, Anjum, I think is VCAS. Is it 200? Is it £200?
It is indeed, yeah.
Yes, and then they get £50 off on top.
Yeah.
Anjum, the AKT mock course is £200, but if you apply the discount code 502020, you'll get an extra £50 off, which means it's £150, and you'll save yourself £50, but only for the first 7 customers. There's 11 people who want to apply. The discount code will lock out at 7, so you can't get that extra £50. Do we get a recording yet? We're recording this webinar. There will be an email sent out 48 hours later.
So just to clarify, guys, so this is the AKT mock, which the next one, of course, is this coming Saturday. So it is a full day. And what we're basically doing is we've already had, I think, Khwaja's on the program, and he's successfully passed his AKT. And actually, I think he got 4 questions from us, which is good. And a lot of the themes that we covered came up in the last AKT. So we pick the high yield topics. You do the first bit on your own. So under exam conditions, we will be there. It is virtual, so you can do it from home. And basically, you will answer the AKT questions. It will have all of the high yield stuff split up into clinical, stats and admin, as it would in the exam. Then you go away for a break at lunchtime, and we resume in the afternoon. And then it's a nice kind of compact learning session, because we've got PowerPoint slides and we go through all of the questions, but we pin them against the NICE guidance. So you get a solid 180 plus learning points, about 200 AKT learning points. It is quite a long day, but it's very useful. And like I said, the guys who went through the first mock found it very useful. And we've done the mock, we've done the exam. So we, obviously look at the RCA and the CSA and the AKT examiner reports to see where candidates did badly and try and predict the next set of questions. So you'll be pretty comfortable. So like I said, the discount code is there for you guys. You'll get £50 off. Do it today, get booked on, pick your date if you're doing it in January or April or October, and then just get going for your revision. So that's the first thing. The second thing was the CSA. Now, I know things have changed. So we're doing the RCA stuff now. So it's basically mainly Dr. Mo with real CSA actors, and you can actually watch the consultation process. And there's 170 plus videos here. Now, I know these are face-to-face, but you can apply the same principle to the RCA examination. So lots of high-yield cases. that have been broken down. You know, you watch Dr. Mo, there's a discussion video, and there's an opportunity for you to practice those cases as well. So the discount code that is typed into the box will give you a big discount on these. There are some trial videos that you can actually have a look at anyway. So have a look, play around with it. If it fits what you're looking for, then obviously go for it, make use of the discount code. So they're the kind of bits and pieces there. We also have, of course, our MRC, GP, AKT, and CSA exam revision group, which looks a bit like this. Obviously, we're streaming into it at the moment. People are asking a few questions. Oh, Mo, you've got another question there, Mo. Maybe you can answer that later. But basically, we post revision material that doctors find very useful. So don't forget to join it. Use it to chat, ask questions with other trainees. For example, there's about 80 of you or 78 doctors, GP registrars in this Zoom today. Now, imagine if you were all in that group and you've got questions to ask, use that forum. We've met some interesting doctors who've told us that their VTS is very poor and they don't get much support and much training. So, you know, utilize the extra. And obviously we oversee this, so you can always ask us questions as well. We've got our Twitter page as well. So again, we're posting some revision material on here to keep you guys up to speed, but also generic things, the latest medical news, so that you can keep up to date with that. So have a look at our Instagram page. It is inspire_medics, Twitter rather. This is the Instagram page. So again, some of you probably are following this, but it's inspire_medics. And you get lots of different revision material and different content as well. That you can use for your revision. And obviously, you know, if you want to get in touch with us, you can get in touch with us on there as well. So you'll keep an eye on some of the projects that we're doing, some of the charity stuff as well. So inspire_medics. So that's kind of an overview, whistle-stop tour of the social media and some of the things that we've got for you guys. And of course, don't forget to join the free AKT question bank. So, you know, you'll see it on the website. There's 2,700 or 2,800 questions. We're adding new questions in at the moment. We're updating the guidelines because there has been some changes like hypertension and so forth. So use it, it's free, share it with your VTS, let them know about it. The other thing as well, that if you do book onto any of these courses, you do get WhatsApp and pre-course and post-course support from me and Dr. Mo. We've got a team here at iMedic, so even if you can't get with us, get hold of us straight away, you just message Corrie, who's our business admin lead, and she'll get in touch with us and we can give you a call or what have you, and take it from there. So that's that. Now let's swiftly move on to the second stage. Dr. Mo will keep an eye on the chat and I will get you onto your second topic. So this is another high yield topic of attention deficit hyperactivity disorder, also known as ADHD. So that's going to be your second topic of your webinar today. It's a high yield topic. Get you ready for your clinics, your day-to-day surgeries, as well as your RCA/CSA, and of course the AKT exam as well. So the objectives: define what it is, pick out some of the key features, how do we diagnose it, and of course, how do we manage this, this condition. So NICE basically describes it or defines it as a behavioral syndrome which has these three features: hyperactivity, impulsivity, and inattention, and we'll go into a bit more detail as to what this actually means. What causes ADHD? Because sometimes parents will ask you, well, what is the cause? Well, we don't know the exact cause. You know, often they don't find a cause. There is thought to be a genetic link, so there may be a family history which may put people more at risk of developing ADHD. But then there's a whole cluster of what NICE calls environmental factors. These are the factors that people are exposed to that can lead to a stronger association of developing ADHD. Some of them can start off in the sort of postpartum or the pregnancy period. For example, a baby who's born either with low birth weight, if there's a preterm delivery, if the mother was smoking during pregnancy. This is very important. This is why we counsel our patients and we say to them, look, try and stop smoking. Talk about the dangers of smoking during pregnancy. Then there's other neurological ways of thinking about it. So epilepsy, so people with epilepsy are more prone to go on to develop ADHD. If they've had an acquired brain injury, whether it's as a child or later on in life. You've got your metabolic causes. You've got lead exposure and iron deficiency could cause it. alcohol exposure during pregnancy, and a history of mental health problems. So, people who are already known to have existing mental health problems like depression and psychosis are more prone to ADHD. And the concept of psychosocial adversity, so people who are born in lower socioeconomic backgrounds may be more exposed to developing ADHD. So diagnosis, how do we actually diagnose it? Remember, ADHD can affect obviously children, which is what we commonly see, but it can affect older people as well. So don't always think it's children. So NICE says to you that you have a criteria. So you have to have at least 6 or 5 if it's an adult of inattention symptoms and or. So you don't have to have all. You can have some of the hyperactivity symptoms, or you may have some of the hyperactivity symptoms. And there's going to be 6 of them for a kid and 5 for an adult. So remember, 6 inattention features and 6 hyperactivity features for a child, and 5 inattention / hyperactivity features in adults. Basically, the symptoms normally, if it's a child, will have started before the age of 12, and they occur in 2 or more settings, which is why in your history you always ask, Mrs. Smith, I know you said you're worried that, Charlie is, he may have ADHD. You mentioned that he does this at home. Tell me what he does at school. What does he do at Nan's house? What are the kind of things that's 2 different settings. And if he's doing it everywhere, that means it's more likely to be a consistent pattern of behavior. The third thing is that it has to be there for at least 6 months. So, because sometimes, children can go through a phase, or adults can go through a phase where they may have some mental health issues, or they're generally just feeling down, and they behave and they develop some of the symptoms, which we'll discuss in the next slide. And so you have to have it for a persistent period of at least 6 months. The other thing is that the behavioral changes have to be significant enough to interfere with the quality of life for that patient in terms of their academic achievements, their work, so how they're functioning at work. All of that stuff is impacted by these symptoms. And it's not occurred exclusively during some kind of mental health disturbance. So, for example, if they've had a mental health breakdown and a crisis, and then they've got the symptoms, you can't attribute that to ADHD. That might be because they had an acute mental health crisis. And again, it goes back to the point of 6 months, because we can prove that it's more consistent. So what are the symptoms of inattention? So I made a nice little diagram for you guys. So inattention, essentially, NICE has given us some little examples, and I've nicely summarized these into a table for you. But basically, it's going to be someone who's failing to give kind of close attention to detail and making lots of careless mistakes. Schoolwork, it might be a project if it's an older adult at work. There might be other activities. They might be in a sports team. They might be in an art club. They might be in a choir or something along those lines. But they're starting to make these kind of mistakes. Now, the important thing to mention, remember, everybody makes mistakes. So all of us, if we have projects, are probably going to make some small mistakes because we weren't concentrating, which is why this bit is important, the 6 months, because it means that someone with ADHD is persistently doing it. They're not doing it once. They're not doing it because they're tired or they didn't eat much or they had a bad few days. They're doing it persistently on a day-to-day basis over 6 months. Difficulty maintaining concentration. So, you find that the inattention feature of ADHD is that these kids are often daydreaming. They're not listening. They're not focused. There's no concentration there whatsoever. They look as though they're not listening, so their mind is wandering. Again, it's a persistent thing, because all of us at some point, maybe we're sat in a lecture. Maybe some of you hopefully are not doing this now, but some of you may be doing that, where you're just staring into space and you're thinking about something else and you've missed what the person in front of you was saying. But again, it has to be persistent. Then there's failing to follow instructions or finish any tasks. So, for example, teachers have given them a task to do and they're just not doing it. And it's not because they've got a mental health problem or some form of, a disability which affects them from achieving that. In other words, they're normal functioning, but they're not managing to complete the task. Difficulty organizing tasks, disliking or avoiding tasks that require mental effort. And of course, losing things like their wallets, pencils, mobiles, and they're constantly doing it. So again, some of us will lose our phones or pencils or what have you, but you won't do it persistently. Easily distracted by external stimuli, and of course, forgetful with regards to daily activity. So this is just a summary. Remember, this is an overview of what inattention kind of looks like if you summarize it. Then there's the concept of hyperactivity or impulsivity. So what does this mean? Well, again, it has to be persistent. So everybody does a little bit of this, and maybe all of us have done a little bit of this. Maybe we still do a little bit of this, but someone who does it consistently day in, day out in 2 or more settings for more than 6 months is possibly going to have ADHD. So people who are fidgeting or tapping their hands and feet, constantly moving around, you know, leaving the seat when they should be sat down, for example, in a classroom, running about, climbing in situations where they shouldn't be, you know, climbing on the table when it's not normal, when no one else is doing it. It's not a PE lesson or anything like that. Constantly feeling restless, not really playing or engaging in leisure activities, you know, being on the go. So as if, you know, there's somebody's kind of, you know, charged them up and they're just constantly going from A to B, talking quite a lot, you know, blurting out things. So often speaking out of line. So for example, if you've got an office or you've got a classroom and there's a kind of order that's there, someone with ADHD will often start talking out loud and answering things in an unstructured and an unruly manner. Difficulty waiting his or her turn, and of course, you know, interrupting other people when they're talking. So how do we manage this condition? Well, in summary, of course, you know, we know what we do as GPs. We try and spot it, and then we refer them on to either a specialist pediatrician, a child psychiatrist. Of course, most of you will be familiar with CAMS, the Child and Adolescent Mental Health Service. That's the commonest place that we refer to. And of course, if it's an adult patient with ADHD, then it's an adult psychiatrist. And mostly, you know, the referral pathways may differ. In this webinar, you guys are from all over the country. You know, we've got some people who are around the corner from us. Some of you guys are up north, some are in the south of the country. So your referral pathways will be slightly different. But generically speaking, these are the specialists that get involved in the management of ADHD. And remember, they're the ones that will actually formalize the diagnosis and then start the treatment. What kind of treatment is there? So the treatment will be started by the specialists. They often focus on things that they can try and help the patient with. So education and support programs. So things like group psychological treatment, CBT. There's lots of kind of group CBT therapy that they do. Some of it's done online. They can also do things like social skills training. So, you know, how to behave in certain situations, how to act in a ruly manner, you know, in a sort of structured manner in different social situations. And that can all be organized through these specialists. They may do individual psychological treatment, so psychological counseling, where they have some therapy with a therapist, and they try and sort of tackle why the child or why the adult is behaving the way that they do. And then obviously you look for sort of trigger points and try to sort of do some psychological kind of remapping to alter the behavior of the child or the adult. And then of course you've also got drug treatment, with the commonest drug being methylphenidate, also known as Ritalin, which I think is the trade name. You've got tamoxifen, dexamphetamine, and so forth. So these are the classic drugs that we're given. In terms of the drug treatment, so if you're working as GPs, whether you're registrars or even when you qualify, you will see some of these drugs, especially this one. So this is the Ritalin. You may see atomoxetine, and you may see this one. I've never seen this one used before, but you often see that there's a shared care agreement. So the psychiatrist sends a letter to the GP saying, you know, Alex Smith is a 8-year-old child, I've diagnosed him with ADHD, and we're going to start him on methylphenidate. I'm going to start the initial prescription. Are you happy to carry it on? I will see him in clinic every 6 to 12 weeks. And normally the GP puts a signature on it. The key learning point from our sides, which they do in clinic anyway, but we should do as well in case it's missed, is that you do have to monitor the child's height and weight and blood pressure and heart rate. So the weight should be monitored every 3 months in children who are 10 years and younger, and every sort of 3 to 6 months after the treatment is started. And then obviously 6 months, you know, and you basically check them every 6 months if it's an older child over the age of 10. And every 6 months you check their weight for adults, have a look at their BMI to make sure they don't gain weight. Height, every 6 months in children and young people, and NICE recommends that you plot this on a growth chart so you can monitor the trend. The blood pressure and heart rate, we just check it before and after each dose change and every 6 months. And again, you just look at the results and you compare it with what should be a normal blood pressure and a normal heart rate for that specific age group. And then a common question, and sometimes they'll ask you as an AKT, or they may ask you as a patient, and now you're doing the RCA. So if you did have this in your telephone consultation, a parent could easily, or an adult could ask you, well, is it linked to my diet? Is it because of something I'm eating or drinking that I've got ADHD? The key thing is that there's actually not a specific link between anything else. The commonest thing was artificial colorings, which you get in foods and additives. But there's nothing to suggest that eliminating this will make you better. So the general advice is that you should encourage your patients to eat a balanced and healthy diet. You know, a little bit of carbs, a little bit of fat, a little bit of protein, not too much fat and sugar. You know, and eliminating, like I said, the artificial colorings and additives from the diet is not specifically recommended by NICE. And the only reason, or the only way you would do that is, or eliminate any food for that matter, or drink, is if you can demonstrate that there's a link between that food or drink and the patient's symptoms. And the simple way to do that is you get them to keep a diary, and they can look for a trigger. If they find it, they can eliminate it and see what impact it has on their behavior. If we know that their behavior is improved, then we know that drink or that food was the particular trigger. And that's it. Open the floor to questions. Before we go back to you guys, just make sure you have a look at our social media channels. We've got lots of revision on there. Obviously, you've had a look. Instagram, Inspire_Medics, where we post lots of daily revision material. Facebook, Inspire_Medics Home, that will take you to our homepage. We've got our AKT and RCA specific Facebook group where we stream live revision lectures like this one, as well as daily learning cards and short revision videos. Also have a look at our YouTube channel, subscribe to it, share it with your friends and follow us. It's Inspire Medics. We've got lots of short revision videos on there. We've got more videos coming in the next few months with lots of new content. And also our Twitter page, Inspire_Medics, for the latest medical news alongside some revision, and Inspire Medics on LinkedIn as well, if you're on that platform. Good, perfect. So that is that. Couple of questions. Narendra, yeah, we will have a recording, so that's done. Anonymous, how long do children continue methylphenidate? Is it for life? Very good question. So normally they will carry on with it for a long period of time, or a period of time that leads to their behavior improving. They'll then be reviewed by the specialists. If they're actually getting better, they could easily be weaned down and see what happens. But it is, relatively speaking, it's a long-term drug. But naturally, some people, as they get older, may say, well, I don't want to be on this drug. You know, you're telling me I've got to monitor my height and weight and blood pressure and all these other things. And so the way the specialists would do it is they'd review the patients regularly. Once they get better, you can make an informed decision, which is, let's pull you off the medication. Let's see how your symptoms are. If you remain well, you can come off it. That'll be the simple way to do that. So Anna, how do you explain to parents that Ritalin is a stimulant to be given to control their overactive behavior? So remember, when you're doing, obviously it's the RCA now, it's not the CSA, but the principles are still the same. So what you don't do is you don't kind of go into the mechanism of action and all this physiology stuff. You keep it nice and simple. You say, look, I know, Mrs. Smith, that you're worried about Charlie, but there is a medication. It's called Ritalin or methylphenidate, whichever word you want to use. Have you heard of this before? So remember, anyone who comes onto our courses knows that we do ping pong, which is hitting the ball back and forth. So between you as the doctor and the patient, so you get a shared management plan. So have you heard of that before, Mrs. Smith? Now, she might have heard of it, in which case it's great. She'll tell you what she knows. But often she will not have heard of it because you're being tested. Well, in RCA it's interesting because actually she might know about it or she might not, because they're real patients, they're not actors. But generally speaking, let's say she doesn't know, then it's your stage. So you can say, well, look, there is a medication that we give and it works on different systems in the body, but essentially it's designed to reduce his overactive behavior, keep him more settled, and it should make him kind of feel more kind of calmer and behave in a more orderly manner. Does that make sense so far? Yes, doctor, that makes sense. Do you have any other specific questions? Keep it nice and simple. Don't go into physiological details. Just simple. It's a medication. It will basically reduce that inattention, that hyperactive behavior that he has. But of course, we do have to monitor his height, his weight, and his blood pressure. Does that make sense so far? Do you have any questions? Good. And fine, good. So basically, any other specific questions? Anything, Dr. Mo?
No, I think that was a question. I think you've answered it. Why is a stimulant given when the patient's already hyper? And I think one of the reasons is because drugs have their effect on certain doses. So yeah, it's a stimulant, but at certain doses, it's enough to control the symptoms that the patient is exhibiting. The example is like paracetamol. At a low dose, it's a pain relief. At a high dose, it can end up damaging the liver. So there's a balance with all drugs. Too much is water. Drink too much water, and you can get a decrease in your sodium osmolality. It can put you into a coma. But at the correct doses, it gives you energy because obviously it hydrates you. So that's the reason why it may be counterintuitive how you can give a stimulant to somebody who's already hyper, but at the correct dose, it seems to, for whatever reason, cause a therapeutically clinical beneficial effect. The only other things to add are we've only got 2 of the AKT discount codes left to use. 50/20/20 AKT mock exam, £50 off. One, I can see someone's going through checkout, so as soon as they've finished checkout, there'll only be 1 discount code left for the AKT mock where you get £50 off. The discount code is 50/20/20. Guys, if you want to grab it, book it now, because I think by the next 10-15 minutes someone will probably have taken that. And then there's 2 RCA gold standard consultation video coupons left to use. That's 30% off 30/20/20. 3 of the coupons have already been used. There's 2 left over. And then VCAS, if you don't mind, the AKT Gold package. Do you want to quickly show everybody the AKT Gold package? Whilst you're loading that, guys, we are recording this webinar. We'll send you the link for the recording in about 48 hours. We'll also send you the invite for the next teaching day within that email at the same time, so you can register for the webinar. We've got a brand new thing called 5 Bullet Friday. Every Friday, you will get 5 key learning points in your inbox. Please don't unsubscribe. It's super useful for your career, for your development, for job opportunities. It's called 5 Bullet Friday. Keep an eye out for it. You'll have it in your inbox on Friday. And then finally, we've got a brand new game feature mode in the MCQ AKT question bank. There's a button at the bottom called game mode. If you click on it, you'll see something special. So please explore the game mode within the AKT free question bank. So VCAS, whenever you're ready, the last thing we'll probably do is show them the gold package for the AKT, and we'll offer them a discount code today before they go.
Fair enough, yeah. Just the only thing to add then, so with the, I think the second question was about, followed up from the first question about Ritalin. So but it inhibits the reuptake of dopamine and noradrenaline. So the theory is that you've got more of it in the brain, and so the patient is able to concentrate a little bit more, because obviously they've got inattention. Obviously, on one hand, you could argue they're hyperactive as well, but the theory is that that little bit more dopamine, a little bit more noradrenaline in the brain will lead to a more focused child or adult patient. So I hope that clarifies a little bit more. Bit tricky, but hopefully that gives you a bit of a flavour. Here's the screen share. So this is basically, remember, our free MRC GP AKT question bank. That's free. Add to cart, and you're pretty much done. We do have additional features. So we've got a box here, which basically kind of gives you an overview of some of the other things that we have. So the free product is pretty good. You get 2,500 MCQ questions with nice guidance feedback after each question. And we are obviously updating the questions regularly. For example, there has been some recent nice guidance changes, so we update them. You also get some revision podcasts, which we've got from the nice guidance summarized, and you get some teaching videos. So you get 3 of them, and you can have a look at them. And you can see one of the first ever video AKT question banks, which is quite good for the visual learners out there. Got a bronze package, which is a little bit more expensive, $9.99, not too bad. You get the same stuff. You get 2,500 questions, but this time you get 10 nice guidance podcasts that you can listen to on the go. And you get 10 of those video AKT questions, which is essentially a question followed by a short mini revision video. And the key thing with the video questions is it teaches you how to read the questions and pick out the cues. It's one of the first ever that we did. Then there's a silver package, a bit more expensive at $49.99. Again, you get 2,500 questions, but this time you get 100 revision podcasts from the nice guidance and 100 of these teaching videos. And you also get some flashcards. Flashcards are pretty good. I mean, I keep them simple. There's basically 13 flashcards, and they're things that a doctor needs to know, whether you're working on the wards or in a clinic, for example, you know, to have the paracetamol and ibuprofen doses for children at various ages, the red flags for the different systems. There's kind of stuff that you should really be aware of, pediatric observations, things that we often forget, and it's nice to have them at hand. And then, of course, you've got the gold package, and this is the monster package. It's got lots of stuff in for those who are prepping for AKT. It's got 3,500 multiple choice questions. It's got another 1,000 questions, and there are more being added. You've got 750 podcasts, so in the entire nice library summarised that you can listen to on the go for your revision. 750 AKT video questions split up into all of the different specialities. Really good revision, especially for the visual learners. And it makes revision a bit more fun as well. And of course, you get the flashcards as well. So the discount code that Dr. Mo has applied to the Zoom chat box.
No, I haven't. Yeah, so for this one, we'll do the first 3 who apply the discount code. We'll get it. You'll get 40% off, which is quite a lot. And the discount code is 402020. Only the first 3. You can choose any package, bronze, silver, or gold. You'll get 40% off, but only the first 3 customers is 402020. With regards to the AKT mock, there is still. I'm going to add on one more. There was 2. It dropped down to 1. I'm going to add on one more again. For the discount code, so one more person can access it, because a few of you are asking, please reserve the place, so we'll increase it by 1. AKT mock, please use the £50 discount code 502020. 1 has already gone, 1's remaining. I'll add on 1 more by the end of this webinar, and then it'll lock out. And then finally, of course, the RCA gold standard videos. I think there's 2 left, maybe 3, and there's a 30% discount code for that. It's 302020. So as I said before, guys, we'll be sending out a link fairly soon with the recording. The podcasts are on average 3 minutes long. The teaching videos are on average about 1 to 2 minutes long. Free AKT for Saya. This add to cart, free checkout, subscribe, fill in your details. You can log in with Facebook if you want, and you'll get the free AKT questions. Vikas, anything you want to add before we wrap up then?
No, that's fine. So thank you very much, guys, for attending. I hope you found it useful. Just let us know. We'll leave it on for about 30 seconds or so for any feedback that you have, or whether you found it useful. Obviously, just keep us in the loop about any new topics that you want us to do as well. And obviously, you know, do recommend us to your GP, VTS, your colleagues, and let them know about us, so that we can obviously keep on producing the content that we're doing. You know, we are trying. We're still practicing GPs. We've got a big team around us now, which is great. iMedics has grown rapidly over the last 12 months. You know, so that's kind of good for us and good for you guys as well, because it means that we can give you more content. And obviously balance our time between clinics and stuff as well. So let us know how you found today. Let us know if there's anything that you want. Obviously, we appreciate you guys spending your Sunday evening with us. A couple of comments have come through. Delapo, the 5-bullet Friday is a great idea. I'm now using dictation to complete my e-portfolio. Thank you for suggesting that. That is the one thing that I would recommend to anybody. So when I was a GP trainee, I used to be watching the football, and I'd have my feet up and I'd have my iPad and I'd press the dictation button, and I would basically dictate my learning portfolio entries. It was so much easier because everybody else used to be quite stressed about it. For me, it wasn't stressful. So, you know, it was easy to do. So I'm glad you found that useful. And if anyone else, you know, it's literally a small dictation button that you've got on your Apple phone or your Android phone or your iPads. You even get it on your laptops and stuff. So most of you will have quite high-tech equipment. So use that. So thank you for that. Fasia, Dalbeer, thank you very much. It was very useful. Thank you for spending your Sunday evening for teaching us. No worries, Dalbeer. I'm glad you found it useful. Madiha, thank you both. Thank you very much, Madiha. Appreciate your kind comments as well. So good, guys. I mean, we're just happy that you guys have found it useful.
Last thing to add, Anna's got a comment. Anna, so we haven't missed your comment. We have moved over to larger servers, as I mentioned early on in the beginning. As a result of the move to the larger server, the Amazon servers, some of you are getting a message which says account has been suspended. What's happening is the website's pinging to the old server and it's not pinging to the new server. What you need to do, if that's the case for you, is delete your cookies and delete your cache within the browser. and restart your computer, and then you should be able to log back into your account, and you should be able to use the discount code. But Anna, if you're still having issues, email us tomorrow and we'll try and get something sorted for you, because we have moved to a larger server. That's the main reason for the issue.
Yeah, so just to add to that, so yeah, so there has been a bit of a, like I said, the server was updated overnight. So if any of you have problems with the discount codes, I'm personally happy to extend that for you. So if there is any problems, just drop us an email, guys. You know, you guys have done well to join us on Sunday, so we'll be happy to extend those discount codes for anybody who wants to come to the AKT mock or the RCA video course or anything like that. Just let us know, guys, because you know, we know that it's been a bit tricky today, because our tech team are currently working on the website and they're doing some upgrades and stuff. So that might mean that some of you will find it a little bit more difficult to get on. So you know, we appreciate that. So not a problem if there's any issues with that. Alina says thank you both. Fasia, thank you, guys, and Stella as well. Thank you, very helpful, guys. I'm glad you found it useful. I think we'll call it at that then, Dr. Mo.
Yeah, we'll wrap it up. We'll see you hopefully in 2 weeks for the next topic. Good luck with all your assessments, of course, and enjoy the rest of your weekend or what hours are left.
Brilliant. Bye, guys.